Good afternoon, everybody, and welcome to this afternoon's session. I'm Jimmy Hunter from Terence Higgins Trust, and I'm delighted to bring to you this session on Symposium, Sexuality, Intimacy and Sexual Health Later in Life. Just before I hand over to Professor Trish Hafford-Letchfield to actually start the session, a couple of T's and C's. You've probably all heard this before. This is a safe space. This is a respectful space. We're here to engage in thoughtful and insightful debate. No tolerance for any abuse or any attack. People will be removed from the session. That's all from me. There will be a quick poll at the end of the session, so please hang around for that. The chat function is open, and you can submit your questions on the Q&A tab at any point, but there will be Q&A time at the end of the session. Trish, I think I've covered everything. Over to you.
Thank you, Jimmy. So good afternoon, everybody. My name's Trish Hafford-Letchfield. I'm Professor of Social Work at University of Strathclyde, and I'm going to chair this session today. And so we've got 4 really great presentations. Well, I mustn't say that because I'm doing one of them, but we've got 3 really other great presentations, which are going to be timed at about 15 minutes per presentation. And so we're going to leave just a few minutes after each presentation for immediate reactions and thoughts, but hopefully that this will give us some space at the end for a plenary discussion. So I'll introduce our speakers before their talk as they're loading up their presentation, but that goes the same for me. I'm just going to start off myself with my presentation. So thanks for the opportunity to talk to you today, and my presentation is based on a systematic review of qualitative studies of what older people have to say about their own sexuality, and it's based on the let me just get to the next slide. Yeah, it's actually based on this publication, which I can make available to anyone who'd like to read the whole review afterwards. But just a little bit about the team that did it. It was a team of us that were involved in a EU cost action on anti-ageism. So you can imagine that sexuality in later life is of utmost concern around anti-ageism, and that the authors came from different places in Europe: Israel, Slovakia, Ireland, UK, Germany and Romania. But just to clarify that we're using the broad concept of sexuality based on the World Health Organization definition, which encompasses sex, gender identities, roles, sexual orientation, eroticism, pleasure, intimacy, reproduction, and stresses the importance of how sexuality is expressed and influenced through the interaction of biological, psychological, social, economic, political, cultural, ethical, legal, historical, religious and spiritual factors. So you can appreciate that that's quite a wide definition, but again, that gives a lot of meaning to how we think about sexuality as part of the human experience. So research into the contribution of sexuality and remaining sexually active to the quality and well-being of older people is increasing. And some of you may have come to our symposium yesterday, where we already had 4 presentations on different aspects of sexuality in later life. And it is a body of work that's really developing, but studies do tend to focus on the biological aspects, and particularly physical changes that come with aging, and often looking at it through the lens of difficulties and dysfunctions, and from the perspectives of professionals. But we were really interested in research from the subjective perspectives of older people themselves, and we wanted to place their voices at the centre of the analysis to understand their views about their own sexuality and how these might shape services and support. And so our review was a synthesis of qualitative research on older people's sexuality from their own perspectives, attitudes, perceptions and personal sexual experiences. So this slide just summarises the design of the study, which I won't go into now. And I just wanted to highlight the text in green to confirm that we're interested in studies where for that included people that were 60 and over, and the selection was based on older people's own attitudes and perceptions about their sexuality and personal sexual experiences. So having gone through, the rigorous systematic review procedure, we found 20 studies, and these utilised a range of methodologies illustrating that there is no single way of engaging older people in discussing sexuality. And it was noted in most of the papers how difficult it was to get people to talk about the issues in some situations, and the difficulties people had discussing the topic. And as you can see, most of the studies were published in the last 10 years, but it dated from 1987 to 2015, and included the views of 437 older people from 10 different countries. And we were able to identify 3 key themes, which I'm now going to go into discussing in more detail. So moving on to the first theme, about which we called social legitimacy of sexuality in later life. This concerns the impact of socialisation and social legitimacy on how people viewed their sexual selves when they got older. And across the studies, older people reported that others always presumed that they were asexual. Women in particular talked about the social silence regarding their sexuality and intimacy, which made raising these issues with friends, family or service providers uncomfortable. And of course, we know there's an emphasis on youthfulness and beauty, particularly for women, which can be easily internalized. And many of the women adapted. They felt under surveillance, and they adapted their dress, not to draw attention. And where they did pay attention to, expressing their sexuality through dress, they could be labelled cougars or acting inappropriately. So these weren't an actual direct barrier to sexual expression, but it did seem more acceptable that men are thought to still engage in penetrative sex, while women should be satisfied with cuddling. And the availability of drugs like Viagra, which I always remind people was originally developed to sort out women's menstruation problems, but there was a market in it for men. We lost out there. They often, that was more legitimate for men, to have a problem and to seek help. And I think also the other thing about women was that they did see expectations of diminished sexual interest with age as a welcome relief for some, and as a legitimate means of escaping this oppressive aspect of their lives for some. However, despite these constraining messages from society, some weren't prevented from enjoying satisfying sexual experiences, and actually talked about the wider freedom as an older person, which allowed them to reevaluate their understanding of sex and sexuality, and to try out new sexual techniques and enjoy a better sex life than when they were younger. And I think if we put this in context of the cohort of people that we're talking about, I think it's understandable that, they may perhaps have been less educated about sex in their day, seen it much more as a private matter. And a lot of people did turn to online communications, such as cybersex, to express their sexuality and look for new romantic relationships. So they're very active in that respect. So the second theme was really just reinforcing this message that it's health, not age, that truly affects sexuality in later life. And people emphasised how, the aging process affected their sexual lives. It was important to them sex was important to staying healthy and was seen as a symbol of vitality, but was dependent on their physical health. And it also, being sexually active, they felt promoted their psychological health. And higher levels of sexual desire were reported amongst those that were physically active and had fewer medical conditions and took no medication. So no surprises there of how physical health does impact on sexual activity, intimacy and desire. But one of the issues was how if a partner had medical conditions, this kind of did often impact on their sex lives, and also that tension when becoming, particularly for women, becoming caregivers, and their perceptions of being sexual or desirable, particularly if the person they were caring for lost control over bodily functions such as incontinence or just day-to-day functioning in their relationships. And among women, estrogen levels with vaginal dryness and atrophy could lead to painful intercourse. And for men, prostatic problems like blood, peripheral vascular disease or medication for blood pressure could also contribute to erectile dysfunction. But what was important is that many of the sexual issues and physical changes are treatable, and older people wanted physicians to inquire about or ask about their sexual needs when they were talking to them about their health issues. And this lack of discussion was very disappointing. And they were frequently offered medication, various forms of pills, pumps and injections, instead of other interventions such as talking therapies, relationship advice. And they were afraid of taking more medication because, a lot of older people don't like taking medication anyway, and they're worried about the impact on their health, particularly women whose husbands or partners were taking Viagra. That was a big worry for them. So how am I doing for time? All right. The third theme is really about the hegemony of penetrative sex. I actually forgot to say at the beginning of this presentation that we really focus on heterosexuality because it's a whole different realm going into looking at other sexual relationships that are not heteronormative. I just meant to add that now. This is about having a narrow definition for sexual activity. Sex remains intercourse. Intercourse means vaginal penetration, and vaginal penetration requires penile erection. This gave rise to feelings of distress, disappointment, frustration, shock, and fear of failure, which could lead to despair, devastation and sense of hopelessness. So really linked to mental health there when people had problems with penetrative sex. From the male participants or in the studies we looked at, erectile dysfunction really struck deep into the heart of their masculinity, making men feel that they had lost their vitality. There was in the studies very little reference to masturbation as a means of pleasure, and most participants in the studies spoke of the significance of romantic relationships, which include penetrative intercourse, as important and desirable. Older people had to reevaluate and redefine sexuality to liberate themselves and enjoy a variety of sexual activities, and they very much explored and experimented. Cognitive and physiological changes can result in a sense of greater sense of entitlement for pleasure and loosened inhibitions and a better understanding of oneself and others. And so for some, sex in later life was described as being better, greater, perhaps due to growing knowledge of one's own body, the ability to derive pleasure from it alone or partnered, and feeling more comfortable with their partners where they did have a good relationship, with changing their sexual practices and not having to pay attention to fertility. And of course, it goes without saying that it was noted that relationship quality is very important in mediating the experience of the aging body. And whilst older women were frequently unhappy with their appearance, this was less important to them in their relationships. So, I think I've got a minute, 2 or 3 minutes probably. So in summary, this review enabled us to capture the idea that sexuality in later life consists more than penetrative sex, although sex remains a popular discourse linked to the biomedical view of sexuality in old age. That disability, illness, sexual dysfunction, or simply life experiences facilitate an appreciation for other aspects of sexuality, such as coexistence, affection, and companionship. And across the studies, older people specified that sexuality in later years had the potential to produce richer, deeper feelings than those they might have experienced earlier in their life. And they reported more pleasure from varied aspects of sexuality, such as cuddling, foreplay, masturbation, and so on. And so our findings reveal the importance of giving attention to health and physical impairments when discussing sexuality, and that sexual dysfunction is more prevalent in the presence of comorbidities and increase in age. And there are things that we can do about this. Descriptive themes therefore focused on sexuality in the light of deteriorating health, and they also suggest that researchers often equate problems related to sexuality with more general health status than actual specific conditions. So taken together, the 3 themes that were outlined today illustrate the complex and delicate relationship between aging and sexuality. And it's really important that we take a much wider perspective on this, and that people are given the opportunities to draw on their own sexuality, and it paints a much more richer, complex picture of how people are forging their own pathways to this important issues. So a couple of implications. It's significant what we do and how we offer support. Having a healthy sex life is a human rights issue. We need to address diversity in sexuality. We need to familiarise ourselves and be comfortable in talking about these issues with people in later life. It's very important for participation and engagement, and actively facilitating access to sexual health care and psychological support. So thank you very much, and I will end the presentation there. Sorry, I think I'm 3 minutes for start. I think I just about did it there. So I wondered, Jimmy, if there are any immediate questions or whether we should move on to the next presentation, which is Jenny. Jenny, I don't know if you want to, if I stop presenting, whether you want to start to upload your presentation whilst we take any questions.
There are no questions currently, Trish.
Okay, well then it gives me great pleasure to introduce Dr. Jenny Dalrymple, who's a registered nurse and a midwife, and Jenny's got over 25 years clinical experience in the NHS sexual and reproductive health services in both London and Scotland. And Jenny's currently working as a lecturer in adult nursing in Glasgow Caledonian University, and she teaches on undergraduate and supervises PhD and master students. And Jenny also holds a clinical academic fellowship funded by GCU and NHS Glasgow and Clyde. And her postdoctoral work has focused on older adult sexual health and sexual health research. And Jenny's going to talk to us now about the need for a life course approach to HIV testing among men who have sex with men. Thank you, Jenny.
Thank you. I'm just going to start by thanking you very much for having me. I'm delighted to be here. And as Trish said, I'm going to talk about a small study that we had published just before the start of the COVID pandemic, which looked at HIV testing among gay and bisexual men who have sex with men, and focused on a life course approach. So just to give you some background to start with, as we know, new HIV diagnoses in the UK are falling and have done since about 2014. And you can see that includes sex between men. This is for the UK. But also in Scotland, we can see the same thing happening across the total categories of transmission, but also among gay and bisexual men who have sex with men. So this is all really good news. But it needs to be said that in terms of eliminating HIV, we're not quite at the top of the mountain yet. From some data here from HIV diagnosis in 2019 in Scotland, 43% of them were among gay and bisexual men who have sex with men, which is very much out of proportion to their background population of about 5%. Also, we know that there are a proportion of undiagnosed HIV, both in Scotland and also in the UK. And this is really focusing attention on testing to facilitate access to diagnosis and onward treatment among the untested subpopulation. But we know that this is not going to necessarily, or at least so far, hasn't been completely straightforward. And as demonstrated here, that among new HIV diagnosis among gay and bisexual men who have sex with men in 2018, 75% hadn't been tested within the 2 years preceding their HIV diagnosis. So just a little focus before going on the changing role, if you like, of HIV testing. It's always been a diagnostic test, clearly, to establish whether someone's got HIV, but it's also moved to becoming a central technology in the biomedical interventions to reduce transmission. So as well as that original purpose of identifying HIV testing enables facilitation to early access to treatment, which then can help improve the success of treatment as prevention by arresting not only the progression of the virus in the person with HIV, but reducing transmission to sexual partners. And also, HIV testing is a core feature of the management of pre-exposure prophylaxis, or PrEP. So in a sense, it has become a much more routinized central stage and technology in the recent biomedical interventions to reduce HIV transmission. And recommendations for HIV testing among the GBMSM community suggest that annual HIV testing is recommended as a minimum if sexually active. But we do know that this is not necessarily the case across all age groups. And with a focus on older GBMSM, we've got recent evidence that they're among the groups who are least likely to have recently tested for HIV. And in case anyone's thinking that's because nobody in older age groups are having any sex anymore, it's absolutely not the case. And a large-scale study based in Europe and published in The Lancet demonstrated that among those diagnosed with HIV among the over 50s, 30% were GBMSM. We know that there are factors associated with HIV testing, and this has been explored over the last decade. And these are some of the factors identified, which encompass not only demographic and behavioural activities, but also sociocultural norms. But what we're less clear about as to whether these factors persist throughout the life course, or whether at different ages across the life course people are influenced by different factors in relation to whether or not they test for HIV. So what we were interested in doing was to identify age-related factors influencing recent HIV testing among gay and bisexual men who have sex with men from the Celtic nations. And just to clarify, the Celtic nations, for the purpose of this study, are Scotland, the Republic of Ireland, Northern Ireland, and Wales. And this was a quantitative subpopulation analysis of a pre-existing online survey of GBMSM. So there were just under 2,500 respondents that we used from the subpopulation, and the participants were 16 or over. They had been sexually active in the previous year, and they identified as HIV negative, or they didn't know their HIV status. And they were recruited from gay-orientated social media websites and apps. And you can see the breakdown across the countries. 50% were from Scotland, 27% from the Republic of Ireland, 16% from Wales, and 8% from Northern Ireland. And just having a quick look at the demographics, we subdivided the data set into 3 age groups. And the oldest age group were 46 and above at the time of doing the survey. And we selected them because they would have been 16 when the first UK National AIDS Public Information Campaign was released in 1987. So they would have entered, if you like, into their sexual maturity at the absolute height of the HIV epidemic in the UK. And that would have included engaging with HIV testing in potentially a very different way to the role, if you like, and the changing HIV testing experience that people may be having now. So I think that's something just to hold on to, that experience among that older age group. And then we subdivided the 2 younger age groups, partly to focus on the very considerably younger age group because they're also associated with not testing, but also the middle age group are those who have been linked with having a higher positive testing rate for HIV. So just having a look at the demographics, the green column are the older gay and bisexual men who have sex with men, and you can see that across the whole subpopulation that around 50% tested for HIV in the previous year, but fewer among this older group. Vast majority were of white ethnicity. Most were educated to degree level and above, less so among younger GBMSM, and fewer older men identified as gay. Fewer older men were single, more older men had a regular male partner, and more older men had a regular female partner. And of interest, about 150 of the respondents identified as transgendered, mainly among the younger 16 to 25 age group, of whom 13% identified as trans. So they were included in the main study. The numbers were too small to break down into separate variables, but it does raise the question of a potential for future focused study going forward. So the factors that we were interested in were some demographics, also relationship status, and we looked at some behavioural factors, hazardous drinking as it's been associated with risky sexual behaviour, also emotional competency based on the Trait Emotional Intelligence questionnaire, which was embedded into the parent survey, and also gay-related stigma. And this used a personalised stigma scale, which included questions on men's awareness of social attitudes about gay people and the perception of the social consequences of being gay. And the variables which were significant at the univariate level were entered into 3 regression models to predict odds ratios and confidence intervals against the dependent variable of testing within the previous year. And these are the overall results. And as you can see, they're divided into 3 age groups. And these were the factors that were significantly predicting not testing for HIV in the year before the survey. So you can see from the 16 to 25s that living in the Republic of Ireland, not having a degree, and scoring higher on the emotional competence scale was associated with not testing. Among the middle age group, 26 to 45, non-gay orientation was not was predicted predictor of not testing for HIV in the preceding year. And among the over 46s, people living in Wales not identifying as gay, and scoring higher on the gay-related stigma scale were associated significantly with not testing for HIV in the preceding year. So just focusing a bit more on those key points, it looks like geographical residence, which was involved in older and younger GBMSM, was associated with not testing, which suggests there's a relationship between location and testing. And this has come up in previous studies in Ireland and Australia, particularly in relation to GBMSM, but not necessarily among age groups. So more exploration of that would be important to see if there are access issues, and particularly thinking about older MSM and how that might relate to transport, cars, access to postal and remote testing. And so there's much that can be done to fine-tune testing to focus on those subpopulations. Also, non-gay identified GBMSM were associated with not testing in both the older groups, but not the younger group. And it is possible that these are subpopulations that have still not been well served by the current interventions and whose needs have not yet been fully met in terms of HIV testing. Among older GBMSM, those scoring higher on the stigma score also hadn't tested significantly more likely not to have tested in the previous year. And this is very interesting. There are previous studies looking at stigma in relation to health. One particularly in the United States associated victimization, internalized stigma and concealment of sexual identity among gay, lesbian and bisexual adults over 50 with risk factors for poor health outcomes. And so it's difficult to know whether or not the stigma score is related to health-seeking activity around HIV testing, or if it's also linked to HIV itself, as previous evidence has shown. There's also been stigma around seeking HIV testing and having a positive HIV result. Some of that data is now moving towards 10 years old, and so it's possible that the landscape has changed following PrEP and also the changing role of HIV testing. But further exploration is definitely warranted to check that out. And among younger MSM, looking at not having a degree and emotional competence, which I'm not going to say too much again about today because the focus is on older gay and bisexual MSM, but just to say these factors were also identified. So the study did break down the data set into 3 age groups and did find factors that were specific to each age group. However, there were some limitations. Obviously, because recruitment was through social networking sites, those who didn't have use of a smartphone would have been excluded. And that could have included more older GBMSM, but also those with learning and potential language difficulties. In short, people who may have very much benefited from being included within this survey. Also, the internet-based survey meant that response rates or duplicates weren't calculable. And also those who have declared sexual activity in the preceding year on the survey, the activity they did declare may not have carried a risk for HIV. So some of our findings might have been inflated as a result. There was a lack of ethnic diversity, which does limit transferability of the study. The ethnic lack of diversity is reflective of the background population within the Celtic nations, but again, it does potentially exclude those very subpopulations among older and specifically other age groups among GBMSM whose needs have not been identified through the study. And of course, the data was collected before PrEP was rolled out in 2017 on the NHS in Scotland, and therefore the landscape may have changed slightly. But there is a presentation coming up tomorrow morning by Jamie Francis, which I think will, looking at the abstract at least, suggest that there's still work to be done in this area and particularly on testing. So just to conclude, we have identified that their age-related factors do influence recent HIV testing among sexually active GBMSM in the Celtic nations, and opportunities should be taken to maximise access to testing across the diversity rather than treating GBMSM as a large homogenous population. Key areas for further exploration should consider older GBMSM in relation to stigma, and also focus on younger GBMSM without a degree, and a look potentially at young trans men in relation to testing. And overall, a life course approach should be considered when fine-tuning the interventions to hopefully reduce HIV right down to zero as hoped in the near future. So just to thank the men who contributed to the questionnaire, the original questionnaire that we drew from, also the organisations listed, and just to say that most of the references are in the study that this presentation is based on. You can see the reference at the top, but those that were used more recently are listed below. So thanks very much. Thank you.
Well, thank you, Jenny, for such an interesting presentation. And I can see that you get lots of claps flying up through the screens. I never noticed those yesterday, so that's really thank you, everybody, for your appreciation. So I can't see any questions in the chat, and I just wondered if anybody wanted to ask a question directly, or any of our other panel members. Jimmy, is there any immediate questions?
No, we have no questions and nothing in the chat at the moment.
It just makes me think of like thinking about one of the issues that I'm aware of is STDs coming up. STDs, I know it's not the same as HIV, whereas it is sexually transmitted, but generally, you know, where would older people go, you know, for all the sexual and gender diverse groups, where would they go to access HIV tests or STD tests in their later life lifestyle? Because, you know, they may not think of going to sexual health clinics, or they may find it difficult to ask their GPs or community nurses about that. I think that's quite an interesting question that I had.
It is, and it's really pertinent for those who are living in rural locations who wouldn't necessarily have access to a sexual health clinic anyway, and might have to rely on postal services or a digital offering. But then a digital offering then presents some problems for people who are getting older anyway.
Yeah, and I should imagine it's quite stigmatized. You'd be afraid of the stigma, you know, to ask in a small community that, you know, you're sort of coming out in more ways than one, you know.
And that kind of stigma amongst older GBMSM tends to be far more set in than it is with younger people.
Yeah. Yeah. Okay. Well, thank you, Jenny. Did you want to stop sharing, and then I'm going to invite our next speaker, Dr. Sharron Hinchcliff, to put up her presentation. And meanwhile, hello, Sharron. So just to say, welcome. And Sharron is a reader in psychology and health at the Division of Nursing and Midwifery in the University of Sheffield, where she leads the Aging and Sexual Health, Sexual Wellbeing Programme of Research. She's got a fantastic website. If you ever want to go on it, you'll find everything, all fantastic resources that if you involved in educational research, brilliant, or working with providers, really good resources on there. And because she's been working in this area for 20 years and uses insights from psychology to address discrimination in healthcare and wider society. And Sharron's recent book addressing the sexual rights of older people is an edited collection which draws on interdisciplinary research to provide health and social care providers with an evidence-based framework to support the sexual rights of older adults. So I'm handing you over to Sharron, who's going to talk about seeking help for sexual difficulties. Findings from a study with older adults in 4 European countries. So over to you, Sharron.
Thank you, Trish. Good afternoon, everybody. I want to share some of the findings from one of our studies that was funded by the Research Council of Norway and led by Professor Bente Treen from the University of Oslo. One of the areas that we wanted to explore in this study was participants' experiences, well, not their experiences, but participants seeking help for sexual difficulties. And the reason why we wanted to explore this specific area was because, sorry, let me move my slide on, was because we know that sexual activity is really important to the quality of life of many older adults. But as we get older, there's an increased likelihood of experiencing a sexual difficulty. And this usually relates to health conditions that we're more likely to be diagnosed with as we get older. So thinking about type 2 diabetes, although we are getting diagnosed with that at a younger age as time goes on. There's arthritis, high blood pressure, heart failure, and so on. And all of these can have an impact on our sexual function and sexual pleasure. And we know that sexual difficulties can cause significant distress to older adults in terms of our psychological well-being. So, for example, older adults who report a sexual problem also report having higher levels of depression and sort of lower levels of mood. And indeed, it can have an impact on our relationships as well. And older adults, there's not much research with older adults looking at their sexual difficulties and how it has an impact on their life and well-being. But that research that has been done does mirror the research done with younger people that indicates that it can have a significant impact on relationship, in that we might sort of engage in more arguments, there might be more tension. Indeed, some relationships actually break up because of these issues. But there's a lot of unmet need, and I think that's something that Trisha's just indicated in her presentation. We know that patients and professionals experience barriers to giving and sort of receiving help for sexual difficulties with the older population. And for patients, they can feel embarrassed. That's one of the barriers. We've got findings that show that older adults might fear a negative reaction from the health professional. For instance, they might fear an ageist response, and we have got examples where participants, not in this study, but in another study, have been said by their GP, for example, have said, why are you asking me this at your age? What do you expect me to do? So there is clear examples of an ageist response there. In terms of the professional barriers, they also can feel embarrassed. And one of the issues that we find is that they haven't been trained in this area. It's something that you need to specialise in terms of sexual health. A lot of health professionals haven't had that training, they haven't had that specialism, and so they feel like they're a little bit de-skilled in knowing how to approach this with their patients. And some health professionals feel like it just doesn't fall within their remit, so why should they bother with that? So in our research, we conducted a survey across 4 countries in Norway, Denmark, Belgium and Portugal. And the participants were men and women aged 60 to 75. So just to give you a sense of the socio-demographic characteristics of the sample, we had just under 4,000 participants. And in terms of percentages, you can see that there's slightly more women than men that took part in the study, and that the majority of them were aged in their 60s. You can see in terms of relationship status that the majority were in a relationship, and they reported their health status as being good or above very good or excellent. They all had education, at least tertiary level education. Some had secondary level education. But you can see from this, I guess, that our sample wasn't as diverse as we would have liked it to be. And indeed, the majority of our participants were in heterosexual relationships. So Our regression analysis showed that distress about a sexual difficulty was the key driver to seeking help with men and women across all of the countries. So we break this down a little bit by asking sort of what was the main reason that you've sought help for a sexual difficulty within the past 5 years. And the top 3 reasons across all countries are here on the slide. So for women, the number 1 reason was that sex was important to the relationship, whereas for men, that's the second most important reason. For men, their most important reason was that sex was important to me, whereas you can see that's the third most important reason that women gave. So if we want to have a deeper look at this in terms of country, we'll have a look at the next slide. So these are individuals that have sought help because sex is important to them. And you can see that across all the countries, men were at least twice more likely to give this response. So one of the questions that I have is it because men feel more comfortable being able to say that sex is important to them? Is it a generational influence? You know, because older women have been brought up during a time when to outwardly say that they enjoy sex and that sex is important to them could bring a level of stigma differently to how it is today for young women today. So is this difference between the genders a representation of that, a reflection of that, or is it quite simply that sex is more important to men than it is to women? So if we compare that to the following slide, we can see that there's more of a gender balance here, and especially in Norway. And that might be because Norway has been ranked as the 3rd most gender equal country in the world, according to the Global Gender Equality Report. You can see that this was a top reason for women, and it was the 2nd reason for men. But Belgium has got similar kind of percentage as gender equality percentage as Norway. So seeking help in the last 5 years because you felt that the change had a negative impact on how you felt. Well, we can see there's more of a gender balance here in Norway again. And indeed, this question that we asked of participants led them to consider psychological components, so sadness, depression, and frustration. So we were really getting into that sense of distress for help seeking here. But if we take a look at the next slide, the gender difference here is the most striking. And this is participants who had sought help for a sexual issue in the past 5 years because they feared that their partner would seek another sexual partner. As you can see, it's predominantly women with a tiny little percentage of Norwegian men. And there's a similarity between Norway and Portugal, which is a little bit surprising, perhaps, when you think about how they're ranked in terms of gender equality, where Norway is ranked number 3 and Portugal is ranked at number 22. But we've found this over and over again in our qualitative research when we've talked to women about their sexual difficulties and its impact on their psychological well-being and their relationship as well. They do often say that they fear that their partner is going to seek another sexual partner because they're not getting the sexual satisfaction at home. And one study by Adam Jowett has found this with gay men as well, who experience erectile dysfunction, in that they fear that their sexual partner is going to seek sexual pleasure elsewhere. So it's definitely something that warrants more attention, but I do often wonder whether it's anything to do with the structuring of male sexuality within society and the male sexual drive discourse that's kind of influencing our thoughts and views in this area. Because the male sexual drive discourse positions men as being kind of biologically sexually driven and therefore in need of sexual satisfaction. So if we fear that we cannot provide that satisfaction, then we do fear perhaps that they're going to seek that satisfaction elsewhere. So where did the participants go in our study when they had a sexual problem? Well, the main sources of help were the primary care doctor and the secondary care doctor, and this was pretty consistent across genders and across countries. But what is quite an issue for concern is that their satisfaction with the professional help received was quite low. Their dissatisfaction was quite high, and we don't quite know why this is, because it's not a question that we ask them. Why were you dissatisfied? So what I'm going to do here, I'm just going to have a look at some of the data from another qualitative study that I've been involved in, just to get a sense of what might be going on here. So this is some of the findings from the most recent NATSL, the NATSL 3, and we looked at the qualitative data that was focused on individuals that reported having a sexual difficulty, an health condition or a disability, or they took a medication that could have an impact on their sexual function and pleasure in the past 12 months. And what we found were things like this. I mean, this example is a man aged 61, and you can see that he's saying that he tried to seek help for a sexual difficulty. He was actually prescribed Viagra, but he was fearful of taking it because he thought that it might interact with the other drugs he was taking, because he'd recently had an heart attack. So when he tried to seek some kind of reassurance or an answer from the doctor, well, the doctor didn't give him an answer. He described it as he was edging his bets, and he was like, oh, you should be all right. And this is what indeed led to the sort of cessation of his sex life with his partner. I've got another quotation from that same study, again, because I think it really sort of encapsulates how a doctor can be quite dismissive when it comes to the sexual concerns of their older patients. Now, this is a guy who's aged 71, and he's been to see the doctor a few times, and he's got erection difficulties. And the doctor keeps saying to him, well, you've got to want it to happen. You know, you've got to want it to happen. You've got to want to have sex in order to get an erection. But, you know, that ended up bringing his sex life to a cessation, because he was not getting any kind of satisfactory response or any help or support from his GP when he was seeking help. So as well as being quite dismissive of this guy's sort of concern and his problem and the thing that he was seeking help for, it also shows that doctors don't have an appreciation of perhaps the sexual response cycle, and that men can still want to have sex in the absence of an erection. Okay. So I thought it was interesting to look at the reasons why individuals who had a sexual problem but hadn't sought any professional help. Well, you can see from the first set of columns that the reason was the symptoms did not bother them. And that has been found previously in other studies, particularly the global study of sexual attitudes and behaviours. But of the ones that were bothered, so if we skip onto the third set of the third chart here, it seems to be that they were taking a wait and see approach because they expected it will clear up on its own. Now, this has been found in research as well, and in particular, we found it in the NATSL study that I've just mentioned, and it indicates a bit of a delay in the help-seeking journey, in that if you're sat waiting to see if it's going to get better on its own, then nothing's actually improving. So the next slide might shed a little bit of light onto this. Okay, so one of the reasons for not seeking help when you have at least one sexual problem was feeling ashamed. Now, this wasn't a top reason overall, but we can see there's quite a few. It was higher in Belgium and Portugal. And we need to ask why this is. Does it relate to cultural factors? Is it because we feel more shame about sexual difficulties if we come from Belgium or Portugal? Is more shame put on the individual for that? Or is it because we feel like we can more openly say that we feel ashamed about having this sexual problem? And I know from my research that speaking to individuals with sexual difficulties, they do carry a lot of guilt and they do carry a lot of shame. And they often encapsulate their experience as one of sexual failure. They feel like they're letting down their partner. They feel like they're letting down their relationship. And indeed, individuals that don't have a partner often don't start a new relationship because of their sexual problem and because they feel ashamed. But again, this is an issue that wants further exploration. So we also asked about seeking help from kind of non-professional sources. And you can see from these two charts here that speaking to a partner, speaking to a friend, and using the internet were the most common responses here. So men were more likely to use the internet, whereas women were more likely to speak with friends. And again, this has been found in the global study of sexual attitudes and behaviours. And I do wonder, especially the latter one, in terms of women being more likely to speak to their friends, if this relates in any way to gender role socialisation. Because girls from a young age are encouraged to talk to other girls about issues, about their problems. And we're encouraged to keep that up as we become adults and throughout our life. So I think these data help to explain sort of what we would call delays in help seeking, in that in the NATSL paper, again, I've just mentioned, is that we found that individuals with a sexual difficulty would spend quite a bit of time sort of doing their own research or looking on the internet, trying to find answers to their problem, talking to their partner, or maybe talking to friends, or trying lots of different things before they actually sought professional help. So this was a step, quite a big step in the help seeking journey, but it often could mean that they were going around in circles and not actually getting anywhere. Okay, so what can we take home from this research? It hasn't been conducted in Scotland, that's fine, it's been conducted elsewhere, but I do believe there are some implications that are appropriate for Scotland's health and well-being. If we want to support older adults' healthy sexual ageing, then we need to be providing good quality care that's inclusive and that's non-discriminatory. It needs to be somewhere where patients or service users are satisfied with the care that's received. And it's actually not that hard to achieve this. We've found in our other research that quite simply being listened to and being taken seriously can increase satisfaction in terms of the consultation with regard to a sexual issue. So this entails working with primary care and working with secondary care. But I think it's important that we engage with older adults as well. You know, we need to ask what they want, what their help and support should look like in terms of this, and can they be pivotal to the conversation, which is effectively about the sexual rights of older adults. But I think we also should explore other informal sources of support, because we might be missing these opportunities, important opportunities to engage with older adults and to support them with their sexual issues, if we focus solely on professional sources of help. And Trish has already mentioned this, but I'm going to mention it at the minute, again, and that is our book, Addressing the Sexual Rights of Older People. And that is because in chapter 12, we give some guidance and tips for people that want to implement positive change within their services or within their research, and to help make that service more inclusive in terms of its delivery. So the final chapter has got some sort of suggestions that people can tailor to their own population and to their own needs. But on a more general sort of platform, you know, I'd be really delighted if you wanted to sort of join the conversation that we're having about the sexual rights of older adults by using this hashtag, because I really think this is a global movement, and we need to work collectively if we are to shift the narrative of this sexless older age and break some of the taboos that we've heard about already in the previous presentations. So just before I conclude or come to an end, these are the two papers that I've mentioned in this presentation, and they're both open access, so they're free to download, and I can put the links in the chat when I finish talking. So all there is left for me to say is thank you for listening. And if anybody does want to get in touch about this work that we're doing, just feel free to drop me an email. Okay, thanks everybody. Bye-bye.
Thank you very much, Sharron. Thank you. There's a lot to think about there. I wondered if
we have a couple of thank yous for you, Sharron, and I found that absolutely fascinating as well. Both, yeah.
Thank you.
From my own perspective as an aging homosexual, we have nothing in the Q&A at the moment, and nothing in the chat. What I would say, Sharron, is if you could put the details, links, and that hashtag also in the chat, we can then start putting that out on social media.
Okay, that's great. Thanks, Jimmy.
Thank you, Jimmy. So would anybody, Maria, would you like to start to upload your presentation, which is the final presentation? And just to say a bit about Maria. So Dr. Maria Horne is an associate professor in the University of Leeds. She's worked in primary care, community and public health in both academic and clinical settings for over 25 years. Maria's clinical background is in nursing, midwifery, and specialist community public health nursing practice. And she's got extensive experience in public and service user involvement when working with communities to improve public health. Her main research theme is the promotion of health and wellbeing across the life course. And she's currently developing research interests in care homes around sexuality and intimacy, and her expertise is primarily in qualitative and mixed methods research. And I just wanted to say that Maria is a fellow of the European Academy of Nursing Sciences. And today, Maria is going to present a really interesting study on supporting care home residents' sexuality, intimacy, and relationship needs, and developing an interactive training program for care home staff. So thank you, Maria, over to you.
Thanks very much, Trish. And what a tough act to follow after Sharron. Thank you, Sharron, for your presentation. It was great. I have changed the title of this slightly, so do forgive me. It was just slightly on impulse and nerves for today's presentation. So I want to just talk a little bit about really who the funder for this particular piece of research was, and a little bit about the research team. It was Abbeyfield Research Foundation that actually were very generous in providing us with the grant to actually undertake this passion of ours around what we've started to call, let's talk about the S word. And essentially what they funded was something around supporting care home residents around sexuality, intimacy and relationship needs. And today's presentation is kind of the first phase of that research, which was about developing an interactive e-training resource for care home staff to be able to look at an underserved population group in this area of care. And the research team is obviously much wider than myself, and constitutes Dr. Jane Ewell, who is the research fellow on the project, Laura Brown, Christine Brown-Wilson, Tommy Dickinson and Paul Simpson. And together we kind of have formed a loose collaboration known as the Older People Understanding Sexuality Research Group. So moving on to the context and background to this particular study, as we've heard across the other presentations, we're very much now aware that having positive, intimate, sexual and relational experiences actually really important for older adults in care settings. And we know that it's an integral part of normal life for most individuals. And again, so research out there would suggest that still 19% of men and 32% of women aged 80 plus still report having frequent sexual intercourse. However, addressing and meeting the sexuality, intimacy and relationship needs for older care home residents in the UK is still currently lacking. And from previous work that we've done in this area, what we have identified is that actually care home staff are often faced with many complex moral and legal dilemmas when trying to balance the needs of those of residents, individual rights and freedom, and the rights to sexual freedom, with the need to actually safeguard vulnerable adults in their care. And these tensions do really persist, currently. However, we can actually accommodate that through training and education. And we know actually there's actually little out there in terms of training and education for care home staff. And so we decided that actually we would take a look at current resources, etc., that there were topics out there, there were current guidelines out there. However, care home staff were largely unaware of them. So what care home staff reported was that they needed this some kind of training and guidance on such a sensitive issue in order to care appropriately for their care home residents. So the first part really, before we even started to think about developing the training resource, we undertook a scoping review to actually just have a look at what information and resources were relevant to supporting care home staff specifically in meeting the residents' sexuality, intimacy and relationship needs. And the purpose here was to identify existing information and resources that, that was actually relevant to supporting care home staff to meet their residents' needs in this area, and then also to try and find out where the gaps were in the evidence base that could actually help inform a future training resource that we would develop. The conclusion of that particular scoping review was that actually there was very little out there around training resources to support care home staff to meet their residents' needs in this particular area of care, and so gave us some foundation to look at developing a training resource, but actually called out for further work to be done in this area and look at maybe more co-design approaches to developing an interactive training package or whatever type of training package. So we developed, the idea was to develop a community-based participatory research approach where we could co-produce with care home staff, with residents themselves, care home residents themselves and their significant others, a training resource that would actually support their intimacy and relationship needs. And here, what we tried to do was to identify the current issues that were facing staff, that were facing residents, that were being cared for, and what family members' issues were in relation to this area. We also wanted to identify and explore gaps in knowledge around the sexuality, intimacy and relationship needs and what those were within the workforce, and try to develop some strategies with care home staff and residents around enabling the utilisation of a potential education and training resource. So in terms of recruitment for the first phase of developing the resource, we actually recruited 4 care homes in total. And there you see just a description, really, an overview of the demographics of the care home and what the CQC rating was at the time of the study. So as you can see, we went for as wide a variety as possible, so that care homes focused on either residential care, those with dementia and learning disability, or those with a focus on dementia and old age. And we looked also at small and medium to large size care homes as well. And the participants that from these care homes, you can see on the right-hand side of the slide. And so what you can see there, quite a variety of people were actually involved in this co-design method. So it wasn't just managers, there were obviously care workers themselves and senior care assistants, but also sort of kitchen staff and administrators, people who perhaps older people may talk to as well. In terms of ethnicity, it was largely a Caucasian sample and mainly female. We only had one male participant for the co-design workshop. So we undertook, if you will, 4 participatory workshops with these care homes. I will go through the stages now. So in terms of workshop 1, this was all about co-producing case scenarios that staff identified in their day-to-day practice and care of older care home residents. So here we discussed with them, we had 2 separate work groups here. One with just care home staff about their particular experiences and case scenarios they came across, and one around significant others and their residents' experiences about scenarios that had occurred to them that could inform a potential e-training resource. So the end product of that, which was actually a really interesting approach, and actually they took to this type of working really well, was that we developed some several real world case scenarios, and we used a sticky wall method because this was a little bit more interactive. It didn't feel like research for them, and they could play around and move items that they thought were of priority, and then maybe subsequently change their minds. So this was highly interactive and worked very well with older residents as well as care home staff. In workshop 2, we looked at co-producing the educational material itself. So we took away the case scenarios and then tried to discuss with staff in this instance initial identified themes that we'd come across through workshop 1. And from this, we tried to identify the educational needs related to each of these themes with staff. We checked with staff whether the scenarios actually identified with each theme that they came up with in the first place, and whether actually it represented authentic examples of day-to-day practice. And we did encourage staff to, again, talk through about any online training in general, or any particular likes or dislikes about training, and indeed whether they wanted anything online. We used the sticky board method again because they found that highly interactive, and it didn't feel like they were committing solidly to something. They still had the ability to change their views or move priorities down. And the outcome of workshop 2 was that actually this influenced and informed the development of a prototype e-resource. And so we moved to workshop 3, and here what we ended up doing was to develop, if you will, a wireframe of what the potential resource could look like in a PowerPoint presentation, because that was the easiest kind of format to take to a care home. So we presented this prototype mocked up in a PowerPoint presentation of what this would look like, what the final e-resource would look like. So we showed them a particular scenario. We looked at the learning design, the aims and objectives, and we showed them some of the interactive links that we thought would engage staff better with an e-resource, such as stop and think and let's explore options within a particular module. The outcome of that particular workshop was that actually we gained further feedback on some of the filmed snippets and clips that we had, and what was good about them, what could be enhanced with them. We gained further information about the interactive aspects of them and whether they were appropriate, and a good feel of what it would be like to undertake that on a virtual platform. And this is just an example of what we kind of presented to them in, if you will, the wireframe in a PowerPoint presentation. So we mocked up what module 1 was, which was for them, it was something about working with families, and it started with a particular case scenario. Here we have Harry and Jean and what their particular scenario was, and you know that you know what the staff issues were about this relationship. So the next slide you see there on the left-hand corner is an example of some of the learning outcomes that we develop with care home staff. And in the bottom right-hand corner, rather, we've got an example of a film clip that actually supported the case scenarios, so that you got more of the story and how things could unfold. Here we staff thought it was really important to link their training to the Health and Social Care Code of Conduct. So this was an example of a quiz, if you will, within the module, which they particularly liked. The final version didn't look like that. And here was an example of an interaction with learners, which is the stop and think aspects, where they could write down their ideas and thoughts about a particular scenario or perception of dementia in this instance. So that was the mock-up, and kind of that's what they gave us feedback on. So we went away with the mock-up and the final feedback, and we essentially developed the e-resource with the help of the digital learning team at the University of Leeds, who had a sort of specialist knowledge, if you will, to make things actually look good online and easy to access online. So in workshop 4, what we did, we took back this final training resource to seek feedback on what the people who contributed to this and helped design it felt about it, and whether actually it looked and felt all right for them. We asked them specific questions here. Tell us about what you thought of the modules. What was the, look, feel, content? Was this the type of education and training that they would like to undertake? Is this what they envisaged it was going to look like? And actually, how would they use it? Would they use it as an individual accessing the resource, or would they like to access the e-resource as a group? And what they thought about the quizzes and assessment measures that would finally come up with, and would this type of an e-resource be useful in their day-to-day practice? We also explored barriers and challenges and opportunities around actually feasibility, acceptability and engagement, and implementing this within a care home environment, which was going to be phase 2 of the project. So the final education training e-resource ended up with 6 modules. Module 1, working with families, capacity and consent and safeguarding, sex and gender diversity, complexity, which focused on sort of learning disability and dementia, expressing and managing sexuality within care home settings, and actually how do we communicate sexuality and intimacy and relationship needs. And basically, I've been on, it's on the Athena platform at the moment, is the e-training resource. And these are snippets of what it looks like. I actually didn't embed any MP3 formats in this because I was conscious of the fact of things potentially going wrong. So you can see here what the final resource, just from one of the modules, kind of looks like. So you have there, starting off in the top left-hand corner, what the title of the module is, a welcome to the module and what they're looking at in terms of aims and objectives, and then moving across the screen to meet Harry and Jean in this instance. And here we have not only an audio, a visual film clip of Harry and Jean, the case scenario for Harry and Jean, but also a transcript for to essentially ensure diversity and that people are able to actually access the material if they're deaf, etc. Here in the top right-hand corner, one of the interactive elements of the programme. An example of Stop and Think in the bottom left-hand corner. Another film clip of what subsequently how care staff subsequently managed the situation that developed between Harry and Jean in the care home, and then issues that they need to consider which unfolded within the Mental Capacity Act, within working with families and people with dementia. And then what care home staff did say was that it was really important that they got a certificate actually to recognise that it actually completed 6 modules of an e-resource. And so the last thing was a congratulations, you've completed the course. They were able to download a certificate, and as you can see, I completed my training this morning. So I'm certified as completing the S-word training. So the conclusion of this e-resource is that actually using those community-based approaches and particularly participatory approaches with both care home staff, residents and significant others was really useful, and it allowed for flexibility and adaptation of developing this and to and froing with this resource with care staff, residents and significant others. It did allow for feedback and constructive feedback and meaningful discussion. And we did think if we're going to use this again, future studies, we might actually add additional workshopping around conversations about how we do this type of work, community-based approaches with older adults and significant others to perhaps prepare them a little better. The e-resource currently sits on the Athena website, and we are looking at how to distribute this amongst care homes. We conducted a phase 2 study, so we've actually undertaken the feasibility study, so we know it's feasible. And I presented that at the the British Gerontological Society conference earlier this year. And so we know it's feasible. Care home staff did engage with it, but did find actually the measures that we assessed attitude pre and post some quite difficult. So we've got some work to do around measurement scales and surveys, but the e-resource itself, they did find extremely useful, and it did change attitudes around older people's sexuality within care home setting, and gave care home staff actually the confidence and ability to manage situations within day-to-day practice. So going forward, what we'd like to do, we want to obviously make this open to more care homes, but we're in a situation where we need to find out how we're going to manage that in order to sort of finance the update of such an e-resource. So I'm in the process of trying to do that. Anybody with any ideas or who'd like to, assist with this, because we'd like to open this up wider, sort of across the UK, please do get in touch. Those are the references, and I would thank you so much for listening to me, and I hope you got something out of that.
Thank you so much, Sharron. That was absolutely amazing.
Maria.
Sorry, Maria.
No, that's fine. That was a lovely picture there. It's gorgeous.
It was really, really such a. Can I just ask? Did who instigated what? Where did the research idea or driver come from? Was it Abbeyfield, or was it?
Oh no, it was from the Opus Research Group. So it's the Older People's Understanding Sexuality. We've been together for quite a while, so it must be some 10 years now. When we started off with some small projects, really looking at exploring what care, looking at exploring sexuality within care homes, and actually how care home staff manage this within day-to-day practice. So and the kind of projects gradually built up from there, and so the Abbeyfield was from a series of small studies. What the conclusion was that they wanted training. In actual fact, the fact that the training was online was fantastic, because this happened over COVID environment, and so we got past the issues of how we're going to access this training, because it was already online. So the fact that we said e-training, great. I mean, and worked, and actually we did identify that actually that works extremely well. The care home staff did need, I have to say, they did need support from myself and the research fellow through this, because life's very complex for care home staff, and so you could go, so you could plan to do training one day, and then something happens, and because it's such a complex environment, they have to drop things, and then you have to sort of chase up to make sure that they're okay and that they can access the e-resource again. So I think going forward, I think we need to consider that. But care homes that had a training person dealt better with that. A specific training person dealt better with that. Sorry, did that answer your question?
No, that was because, as you know, I've done work on LGBT inclusion in care homes, and I was just thinking about how the two, how the two might complement each other.
Great. Any questions?
We don't have any questions, but I must say I found all of those presentations absolutely fascinating and really informative. And Maria, just to reflect on some of the points that you were touching on, at THT, we've had an increasing number of requests to go into care homes and provide support for people who are living with HIV, because people who are living with HIV now are living longer. Previously, they didn't go into care homes. That's becoming quite an issue. And, it's not only supporting the clients, but supporting the care home staff as well.
Yeah, that's pretty brilliant. Yeah, and I think there is this, which brings Trish's, I think, comments in. There's a wide diversity coming into it. There's a growing older generation, from the rock and roll generation, the flower power generation. Diversity, it's so much more complex now. So something like this, is, care home staff were keen on some kind of e-training resource, because they just don't know. And I think Sharron touched on that just don't know factor earlier with healthcare professionals in community practice. So it is certainly an area of need.
And we have a comment from Julia Ringsell from THT's Peer Support Scotland programme saying, I love this collaborative resource. Utilising end users to design and contribute is definitely the way forward. And Dr. Sally Brown, in her opening comments yesterday, referred to what she saw as the lack of co-design and co-production in academia, but I think across the board as well, if it is fair to say.
Yeah, I think it's so important. I mean, vastly important. And thank goodness that sort of the new health and social care grant schemes and things like that really do go for co-design methods now. So that's a step in the right direction. And actually, it's such rewarding work. It really, really is, because actually at the end of the day, they're the end user, they're the people that are using this. So it's brilliant. Can I just say, actually, because I've just seen Sharron, we had a fantastic steering group as well, of which Sharron was a member of that. And even that steering group, research steering group, was widely representative and had people from charities that were looking at older people and disabilities on that as well. So it was a very much in the round collaborative venture.
Yeah. Yeah, I remember, you know, I was talking yesterday about Paul Simpson, who leads the SILF, you know, Sex in Later Life Forum. And just before COVID, when it was Valentine's Day, they had an event with Public Health in Manchester, inviting older people to come in and talk about sex, and they had sex toys and sexual health services, and it was absolutely mobbed. So obviously, you know, there's a real, people really need to know where they can go. We need to tailor both mainstream, and we need to really like think about what they want. You know, they give them a chance to tell us what they want. Well, it's 1 minute and 45 seconds to go, guys, to ask your sexiest question yet. If you don't, whilst you're posting that hastily in the chat box, I just would like to thank so much our presenters, and thank you, Jimmy, for your support, and everybody who's here. And just to say that, you know, it is such a big topic, so many elements and good food for thought. So thank you very much, you know, for coming along today, and we hope you enjoyed it as much as we did.
Thank you all, and I would encourage everyone to complete the polls. We'll keep the polls open for a few minutes, and thank you to all four of you. Those presentations were absolutely wonderful, and I think more than anything, it displays exactly how much work there still is to do around this subject.
Thank you, Jimmy.
Thank you,
You're
Jimmy.
welcome.
Yeah, thanks, Jimmy. And thank you, Trish, for bringing us all together.
It took a while.
Yeah. Thank you, Trish.
Okay, so if that's us done now, we will end the session. Thank you, everybody, for turning up this afternoon.
Let's go backstage.
Thanks, everyone. Lovely to see you as well, panel.
Yeah, thank you.
Lovely to see you. Thanks very much.